Hi, my name is Ryan Anderson. According to the National Institute on Drug Abuse, 46,802 people died due to an opioid overdose in 2018 in the United States alone. Approximately 10.3 million people aged 12 or older in 2018 misused opioids in the past year. However, these numbers are an extreme underestimation of the lives affected by opioids. It not only affects those who struggle with opioid use disorder, but their families and community as well. Nearly 1 out of 3 people know someone who is addicted to opioids. In this presentation, I will be addressing the ethical implications of long-term Suboxone use. Suboxone is a sublingual film that is a combination of buprenorphine and naloxone and was created to help those with opioid use disorder overcome their addiction. Buprenorphine is an opioid partial agonist. This means that, like opioids, it produces effects such as euphoria or respiratory depression at low to moderate doses. However, these effects are weaker than full opioid agonists. It has a ceiling effect, which causes the effects to level off even as doses increase. Naloxone is an opioid antagonist that prevents overdoses by blocking the receptor sites. If the combination is taken sublingually as directed, the small amount of naloxone available should not interfere with the desired effects of buprenorphine. If the combination is injected by a person addicted to opioids, the increased bioavailability of naloxone would cause an opioid withdrawal. When prescribing Suboxone, a provider faces a significant ethical dilemma: whether prescribing long-term Suboxone further contributes to the opioid epidemic. Healthcare providers were once told that opioids were not addictive. The same goes for Suboxone. Providers were told that Suboxone is a safe way to wean people off of opioids, and it will improve the treatment of their patient with opioid use disorder in a non-addictive way. United States versus Endeavor, Inc. in 2019 pertains to the ethical implications of long-term Suboxone use because the company Endeavor is the company who created Suboxone. They increased the sale of Suboxone film by telling people that it is less abusable and less divertible than other drugs. The American Addiction Center warns about the dangers of Suboxone use. It may help in the short term, but in the long term, it's still an opioid and very addictive. This is why the United Kingdom shifted its drug treatment policy to emphasize the importance of helping those with opioid use disorder to become drug-free. The UK strategy clearly recognizes the prescribing services as an important facilitator of patients' recovery from opiate dependence, though there is also a clear recognition of the risk that patients may develop dependence to prescribed opioid substitutes and fail to progress towards recovery as a consequence. They recognize that Suboxone is an addictive drug, and that even though it may not be as strong or as dangerous as other opioids, these harm reduction methods should not be the end goal of addiction treatment. Archbishop Francis, the permanent observer of the Holy See at the United Nations, stated, "Such efforts do not respect the dignity of those who are suffering from drug addiction, as they do not treat or cure the sick person, but instead falsely suggest that they cannot break free from the cycle of addiction." John Berhaney's Process for Bioethical Decision-Making for Catholics is an ethical decision-making framework that allows for this dilemma to be explored in the context of healing the entirety of the person and recognizing their human dignity, not solely focusing on the disease. There are many questions to be asked about a widespread epidemic, one being whether long-term Suboxone use further contributes to that opioid epidemic. It not only touches on faith and reason, but it brings in medicine, law, health policy, and the healthcare industry all into the decision. The moral object of prescribing long-term Suboxone is to allow the person with opioid use disorder to use their drug of choice, opioids, with the intent that it is safer than street drugs or prescription opioids. This is a harm reduction approach. By prescribing long-term Suboxone, the good effect of preventing unnecessary harm from unclean needles or tainted street drugs comes about by continuing their addiction. It is important that this is specific to long-term Suboxone use. Long-term Suboxone use is defined by a patient who is prescribed Suboxone without a tapering plan or with an indefinite medication plan. This distinction is necessary because with short-term Suboxone use, or Suboxone use with a set tapering plan, the provider is assisting the patient to be drug-free in the end. There is an end goal in short-term Suboxone use. It isn't providing the patient with a dose of opioids to help feed their addiction. Though harm reduction efforts are commendable, intent is not enough to make an objectively bad action good. St. Thomas Aquinas says, just as the primary goodness of a natural thing is derived from its form, which gives it its species, so the primary goodness of a moral action is derived from its suitable object. Prescribing long-term Suboxone or prescribing Suboxone without a tapering plan is implicit formal cooperation with evil. Implicit formal cooperation with evil is when a person, for the sake of a good aim, establishes the structure by which a specifically described immoral action will take place, grants formal approval to an immoral action, or wills the principal agent's evil action as the means for achieving some other good. When a person uses opioids, they temporarily suppress their full cognitive function. Even though buprenorphine is an opioid partial agonist, it still temporarily suppresses full cognitive functioning. If our obligation to be moral is unconditional, then temporarily suppressing one's cognitive abilities is compatible with discharging our moral obligation. Our obligation to be moral is unconditional, therefore temporarily suppressing one's cognitive abilities is compatible with discharging our moral obligation. We have an obligation to always be moral, to always make choices that are good. Compatible with discharging our moral obligation means in more general terms that it is immoral. And is throwing out our unconditional obligation to be good and upright people. No one wants to make the claim that we only need to do good sometimes and bad other times. Opioids such as buprenorphine produces some symptoms such as euphoria, followed by clouded mental functioning and other symptoms similar to opioids. This is temporarily suppressing one's full cognitive function, and therefore is immoral. It is important to note once again that this is immoral. This is only immoral if there is no medication plan, such as tapering. It is not a harm reduction approach because there is a medication plan. The ethical and religious directives state the inherent dignity of the human person must be respected and protected, regardless of the nature of the person's health problem or social status. There is a societal pursuit to stop the stigma of mental health. However, by prescribing Suboxone for opioid use disorder without a tapering plan, are providers contributing to that stigma? What a provider is saying in the moment to their patient indirectly is that I do not believe you can quit fully. Just as the Holy See said, these actions fail to treat the whole person and falsely suggest that they cannot break free from the cycle of addiction. This is how providers are able to live out their duty to respect and protect the dignity of their patients. In order to exercise the ability to abide by the unconditional obligation to be moral, Catholic moral tradition lays out the 4 cardinal virtues. First is prudence, right reason with respect to action. Second is temperance, which allows us to use moderation of desires and pleasures. This applies to things such as drugs, alcohol, food, and much more. The third is courage, the desire for that which is difficult to obtain or avoid. This virtue is in the Serenity Prayer that is prayed at every Alcoholics Anonymous meeting and most other group meetings. Grant me the serenity to accept the things I cannot change, and courage to change the things I can. Group meetings can be helpful because a person who struggles with the throes of addiction are around others who are open about their battle as well. The last is justice, rendering to each one his due. This has to do with our relationships with those around us. It would be a failure upon the provider if they didn't in some way try to grow these virtues within their patient. Father Tad states, the individual caught in the web of addiction objectively falls prey to the loss of personal freedom. The only way to break through the loss of personal freedom is by a holistic approach to addiction medicine. Suboxone can only do so much for the patient. The rest is up to them and the care team. This care team should have people that are able to address the physical, spiritual, social, and psychological ailments. It is not until all these are addressed that a person will be able to fight their addiction from its source. The moral object of prescribing long-term Suboxone is to allow the person with opioid use disorder to use their drug of choice, opioids. Therefore, to answer the question, does long-term Suboxone use further contribute to the opioid crisis, the answer is yes. There must be an implication to the answer to this dilemma. It leads to new best practices for prescribing Suboxone if the provider is truly keeping in mind the dignity of their patient. It leads to new best practices if the provider does not want to further contribute to the opioid crisis. Providers have a duty to not only their patient in front of them, but also their community. Short-term Suboxone use or Suboxone use with a tapering plan keeps in mind the patient and their entire community. Short-term Suboxone use with the help of a care team treats the entirety of the patient and upholds the human dignity of not only them, but the community at large. This should never be a never-ending treatment program. Opioid use disorder is not something that ends with the tapering of Suboxone. The treatment program needs to be a commitment for life. With the help of courage, justice, temperance, and prudence, a patient is able to take on this hardship. Cravings will come and cravings will go, and with these virtues and with this new best practice of prescribing, a voice will be given to those who have never had a voice. Dr. Manchester said it best: if ever there was a group of people who are harassed and helpless, like a sheep without a shepherd, it is this population. Providers have a duty to be that shepherd and give them the voice they so well deserve.